All right, you guys see a radiograph of a young patient?
Yes.
So
Yes.
this is a quick one from my pediatric colleagues, and one of my residents showed me this from when they were on call. 30-month-old that comes in, has this radiograph, and you can look at it, and there's a finding that, you always wonder when you see something on a single view what this is, and then when you look on the lateral view, we see that this elongated metal object, which is, let's see how long this thing is, because the patient's so small, 6 centimeters, so about 2.5 inches or so, is projecting over the right upper quadrant. And this patient had come in with some just fever, generalized symptoms, malaise, and whatnot. And so it's pretty peculiar foreign body in the right upper quadrant. And they went to CT, no history of ingesting anything. But as you will see, I'll start at the bottom, that this thing is in the duodenum, as you can see here. As it comes up, there's actually a small little secondary fragment, it's right around in here. But this perforates through the duodenum, straight up near the porta hepatis and into the liver. And you can see there's a little tiny abscess along the tip of this. And you can see how it's a little complicated fluid collection in the liver. So this actually had to go to surgery to retrieve this. The surgery wasn't really that complicated. This turned out to be a fragment of a bobby pin. So like half of a bobby pin was what they pulled out. And it sure enough had gone through the duodenum up into the liver. And yeah, so just an interesting, interesting foreign body here. So I thought that was a nice one to warm up with.
That's a big bump.
But I think, again, yeah. Well, and I guess that, and also, obviously, if you just see stuff on single views, we always think maybe it's just something overlying the patient. And of course, the benefit here is having the lateral view as well. But this is a pretty unusual foreign body there. Yeah, I don't know exactly what type of pin or hairpiece it was. They said it was a bobby pin, though. But you're right, Jeff, it is kind of big, and it's only part of it.
Wow.
So this is a somewhat exciting case, an unusual complication of a usual finding that we see. And this is a patient who presented with fever, cough, right-sided chest pain, some generalized symptoms. And you can see there's a right-sided pleural effusion, and it may be somewhat loculated. This is an upright view, and it tracks laterally along the right hemithorax. And you can see it here too. The right lower lobe and portions of the right middle lobe are obscured by the effusion. So in this setting, you would assume that there's a pneumonia. Given the patient's history, it sounds like they have symptoms of pneumonia. They weren't doing that well. They actually were like bordering on sepsis, so they got admitted and got the CT. And you can see that there is some loculation to this. Not a lot of pleural thickening, but it's certainly, there is probably some parietal pleural thickening anteriorly here, but multiple locules. So either a parapneumotic effusion or perhaps even a developing empyema. And you can see the pneumonia in the right lower lobe. There's a lot of necrosis too. There's several areas of lower attenuation and just distortion of the normal parenchyma, whereas maybe a little bit of this you'd say is just some passive or compressive atelectasis next to the effusion in the superior segment of the right lower lobe. Yeah. So keep an eye on this area. They put in they put in a pigtail catheter, drained the effusion. It actually grew strep anginosus. And some of the effusion wasn't growing or wasn't draining, so they instilled some TPA and DNase into the pleural effusion. Here he is on a few days later in the afternoon. You can see there's still some fluid left, and here he is 4 hours later, and we can see there's now complete whiteout of his right hemithorax. Now there's a little bit of volume loss on this side, and I think that that's probably intentional, as you will see. And whenever you see acute whiteout like this, you think of, is it atelectasis from volume loss, or is it something else from volume gain? He also has a right-sided IJ catheter. He started having massive hemoptysis at this time, and so they put in a dual lumen endotracheal tube, as you'll see. So one lumen's in the left main stem bronchus. So he was having large volume hemoptysis, stabilized him, went to CT here, and I'll show both arterial and delayed images from this study. And you'll see the the right upper lobe has some atelectasis and some additional foci of pneumonia here. Still has a large effusion. It's not really that the effusion has gotten that much bigger, it's still there. But if you'll see in the area of necrosis in his right lower lobe, that one of our fellows saw this on call, you now have a blush of active extravasation in the right lower lobe. And then there is some associated increase in pleural effusion, and this is high attenuation hemorrhage here. So this was presumed to be a necrotizing pseudoaneurysm from the right lower lobe that had ruptured from the pneumonia and caused hemoptysis, and in addition to hemothorax, as you see here, and the pigtail catheter still in there. So they went to selective catheter angiography, and I've pared it down to about 3 of the runs that they did. They were doing selective of every segment in the right lower lobe, and you'll see this is the medial basal segment that's being selectively injected, and you can see here is that big blush in the right lower lobe and that big pseudoaneurysm there. So they were able to successfully coil this. Let's see, that was one. Then here's a super selective, I think, where they're getting into a subsegmental branch. You see the same thing. And then eventually they coil that. And now you can see when they pull back and inject that they've effectively stopped blood supply to that. So mycotic pseudoaneurysm from strep anginosus, so not a Rasmussen aneurysm, but basically the same thing, since it's a different organ or different organism. But there you can see the coils afterwards. So I think, Jeff, I know, yeah, and I know, Jeff, I think you've shown like necrotizing pneumonia with pseudoaneurysms before. I don't remember ever seeing one rupture like this.
No, the ones I've shown have resolved. Usually they treat the infection and sort of keep an eye on it, and it kind of scars down.
All right, well, this is one I will I'll start with a radiograph and give you guys a second to see what you think here, and feel free to comment.
Okay, I'm concerned about I'm trying to decide whether the aortic arch and the adjacent mediastinum is abnormal, and there may be pathology between it and the trachea, which may be displayed right lateral.
Good, right. And I think you'd say you can argue the left mainstem bronchus is inferiorly depressed as well.
Yes.
But yeah, certainly a bigger than expected aortic contour if this is the aorta. I'll show you a scout from a CT from 3 years ago because he had a known diagnosis, and you can see, unfortunately, I don't have a lateral and I don't have a prior radiograph, but still a little bit of that abnormal contour here. I think you said this is probably the aorta. There's an extra contour here, but none of that mass effect on the airways is there. So that's the finding, and this was in 2013. And you see that the finding is actually posterior to the aortic arch, and it's a very sharply marginated, simple appearing or homogeneously appearing, relatively low attenuation structure in the middle mediastinum. It's adjacent to the esophagus. It's around 20 to 25 Hounsfield units, and so at this time he was diagnosed presumptively with a bronchogenic or a foregut duplication cyst of some sort, which I fully agree with. And I guess he got, for some reason, I think this was for AFib planning or left atrial mapping. I don't remember why, but they got another CT later. This was a few months ago, and this had gotten a little bit bigger at the time. It's still intermediate attenuation. He was asymptomatic at this time. So this was the end of December. The end of February, the endoscopist did a transesophageal, basically attempted drainage or biopsy and drainage of this thing. And this radiograph was about 2 weeks after that, the one I'm showing here, when he came in with new onset of chest pain and fever. And so this is the subsequent CT that I saw from overnight. This, of course, no surprise, is a PE study, but you can see now it's gotten even bigger, and there's a lot of inflammatory stranding surrounding this now. You see there's fat stranding inferiorly in the mediastinum, a little bit above it as well, and maybe even a little bit of distortion of these fat planes surrounding the esophagus. So we thought this was probably a superinfected foregut duplication cyst. I actually didn't even know the history of recent aspiration of this. It just looked like it had become infected. So he went to surgery, had this taken out, and this did turn out to be a foregut duplication cyst with mild acute inflammation. So this turned out on histopathologic analysis to be a bronchogenic cyst based on the histology rather than an esophageal duplication cyst. But I wonder if they had not touched it, if it wouldn't have become infected. I bet they introduced something into it with the biopsy. What do you guys think?
Agreed. Agreed.
It's possible, yeah.
Temporal proximity. Temporal proximity.
And since the esophagus is certainly not a sterile organ that you're going through with your needle. So, and this is a new location for me to see one here. I don't usually think of them. Of course, we're in the middle mediastinum along the foregut, but it's, you know, having it right around the aortic arch is you know, somewhat different.
Right. Wow.
And now this one, I wish David was here because he loves all the crazy infectious cases. But this is one that I've been waiting for the autopsy, which finally has been finalized, unfortunately. As you see, this is a 44-year-old man. End of January, he went to an outside hospital, and he had had a few weeks of just worsening malaise, B symptoms, developed some cough. And you can see on the radiograph, his lower lobes are a little bit busy, and maybe you can tease out some areas that look a little bit more discreetly nodular. And this kind of pans out on the lateral view too. There's some respiratory motion, but he's just a little bit busy.
Yes.
He ends up undergoing a CT that day. Or what were you going to say, Howard?
No, I agree. Go ahead. Sorry.
So it's an interesting CT because he has a bunch of little nodules. As you can, some of these are small little, you know, 2-3 millimeter nodules in the periphery. It's relatively symmetric, and then some of them coalesce into other areas of nodular consolidation. It's more peripheral than central, but still relatively symmetric and in the lower lobes. And he also, and this was all done at the outside hospital, he also has some lymph nodes. This left hilar node may be a little lower attenuation than some of the others. But he wasn't getting any better, still febrile, cultures all negative, and couldn't find a pathogen. Turns out he had diabetes. They didn't know that he had cirrhosis at the time, but you can see that his liver's a little nodular, and he has splenomegaly as well. So I actually went to a VATS and did both mediastinal node biopsy and a surgical lung biopsy. And you can see that here he is a few days later, he's got the chest tubes, and then he gets transferred to us as, you know, 6 days later, he's now totally gone downhill, is intubated, and has just a typical look of diffuse alveolar damage superimposed on this stuff in the lower lobes. So he's got diffuse consolidation, diffuse ground glass opacities, and not necessarily traction or not necessarily bronchiectasis at this point just because he has acute issues, but these airways are definitely dilated, typical look of diffuse alveolar damage. No effusions to suggest that this is hydrostatic edema, or at least from heart failure. Around this time, the biopsies came back. Most of the stuff in the lung was just organizing pneumonia, and cultures were negative. But his lymph node biopsy, surprisingly enough, came back positive for Bartonella henselae. And it was then that they questioned him and found out that he had 7 cats and 4 chinchillas in his small apartment in San Francisco that he lives in. So cat scratch disease is usually, you know, a loco-regional lymphadenopathy and cutaneous thing, and only rarely causes disseminated disease. I can find only case reports of lung nodules, of pneumonia being associated with this. But between that and his VATS, which may have precipitated the ARDS picture, he actually, unfortunately, passed away a few weeks later. And you can see this is just this was the next CT, you know, shortly before he died. And you can see just typical findings now of like organizing phase of diffuse alveolar damage and a lot of pneumomediastinum as well.
Gosh.
And
Travis,
Yeah.
You know if chinchillas carry Bartonella?
I looked. I cannot find anything regarding chinchillas carrying Bartonella, but his 7 cats certainly.
That's for sure.
Yeah. But yeah, so here was he lives in it was a pretty small apartment, 7 cats, 4 chinchillas. And turns out from my reading, the positivity of IgM is very suggestive of acute infection. And the ID people were, working him up for everything. They couldn't find anything else. And then I included some of the autopsy expert. They did find Bartonella, or they did find bacteria in the spleen that they thought was Bartonella. And that's an organism, when it does disseminate, the spleen, the liver, the brain, central nervous system are places that it goes. But it turns out the lung was really just organizing ammonia, both exudative and proliferative, proliferative phase of diffuse alveolar damage, ARDS. So the disseminated infection, I guess those nodules in the lower lobes are probably part of the infection before he really had just, typical organizing pneumonia with this stuff. And that precipitated, the sepsis and eventual diffuse alveolar damage. So.
Is it a bacterium? It's a bacterium. I don't know anything about the Bartonella. But
it's a fastidious gram-negative bacterium that is very difficult to isolate in cultures. But that's why having the IgG, IgM titers are usually the best way to make the diagnosis. But usually it's just patients and often kids that have a cutaneous thing with palpable, tender lymph nodes that are regional to where the scratch occurred. So it's usually introduced by a scratch, and only rarely does it disseminate. And there's according to UpToDate, nobody knows why it does disseminate. He had type 2 diabetes, and turns out now he has cirrhosis as well, which may have predisposed him to being immunosuppressed. But generally, an immunocompetent host, it doesn't do anything more than a local cutaneous and lymph node thing that's often self-resolving.
Gosh.
So, Jeff, I will stop there.
I've
got some more queued up if we need me to fill some more time.
Okay. Howard, you want to go next, or I can go?
Go ahead, and I'll go after you. That's fine.
Okay, let me see here. Sorry, I'm navigating with my laptop. For some reason, I can't get the GoToMeeting to work on the Mac. Let's load here. All right. Well, I have a case. I'm curious. I also wish David were here, and I kind of sent Travis a little preview. Let's see. All right. So here we go. Let's see. So this was an incidental finding that we came across yesterday, and a guy, I can't remember what he was scanning for, but totally unrelated. But he clearly has these plaques in his pleural space. You do see my screen, right? Did I hit the right button?
Yes.
Good.
Yeah.
He's got these he's got these plaques in his pleura. I mean, they're not quite as flat as we typically see with asbestos plaques, but for all practical purposes, they're plaque. And you can see this one's even remodeled the rib, which I've shown a few examples of. But what's so striking is this posterior soft tissue here. It's like a confluent area of pleural thickening, and he also has some diffuse pleural thickening and pleural plaque. And he's got the classic diaphragmatic plaques. These are just more mass-like plaques, sort of tumefactive. But I'm having a hard time trying to explain this. I went back. The only thing I could find was an old spine CT from many years. I mean, the CT is actually 5 years older than the radiograph. You can see the nice plaque on FOSS, see them on the diaphragm. So, I mean, it looks all the world like asbestos, but I have never seen plaque cross midline. I mean, short of, a horseshoe lung or some fusion of the pleural space. But it's interesting because the descending aorta passes behind this right there. So
yeah, and it's deformed too.
Yeah. So he must, I guess, have a variant of a horseshoe lung. I just don't have any better explanation. I was curious if Howard had ever seen anything. I didn't know if Seth was going to do it either.
No, that's perplexing. Gosh.
Yeah. So when David gets back, I'll probably show this again because, he's been doing occupational stuff for several decades. So maybe he can enlighten us. But that's my working theory, that there's probably either fusion of the pleural space, but given how confluent it is and the aorta is behind it, that it probably is a variant of a horseshoe lung.
Very odd.
Okay. All righty. So now here's a little companion case with it. This is just a nice teaching case. This was a patient who was being followed up for a cancer, and not why I'm showing it, but the real interesting thing, and you'll see there's plaque here, and these are some of the shaggy plaques, but they're less lumped up than the ones I just showed. But what she has is a really nice example of what was described in a couple of papers of the subpleural curvilinear lines that have been thought to be more suggestive of asbestosis than IPF UIP. As far as versus asbestosis like UIP. Now her fibrosis is pretty mild, but she's got these really nice subpleural bands. And there was an old paper, and I can't remember when it's from, but it made this the comparison. They compared IPF to this. The other finding people have talked about are subpleural dots, which I think there were. Oh, I've got to mute this here. There we go. Where they describe these subpleural dots that you might see out in the periphery. And what those are thought to represent, I think there were a few on here, is peribronchiolar fibrosis. I think this is a better example of the subpleural curvilinear lines, but this is one of the better ones I've seen. So, suggests some early asbestosis in this patient with plaque. Now, the only exposure I could find is she used to work as a sales rep in the petroleum industry many, many years ago. She's much older now. I believe she was in her 80s. So this would have been, back in the 60s. So who knows what she was exposed to at the time. But that's the only exposure I could find.
Very interesting.
So this is an interesting case, and I'm curious what you think. I have an observer with me from Malaysia, Mohammed, who I met in Singapore, and he shared this fascinating case. And let me bring up the history first. I have it in here somewhere. All right, so it's a 62-year-old who had some chest pain, and we'll get into the CT, but you can see overall the exam wasn't particularly exciting. And the lab workup, for the most part, is normal. There's really no autoimmunity detected, no HIV or anything like that, no ANCAs. I'm going to show you the CT. There is an MR, but I'm just going to start with the CT because I think it probably shows what we need to see. And all the action is in the coronary arteries. And you'll see there's this diffuse soft tissue thickening around the right coronary artery. You see it around the circ and also the left anterior descending. And it's quite striking in the right coronary artery, but the lumen is preserved. There's no luminal filling defects. It's just this massive soft tissue. And, we were talking about this case and kind of racking our brains. We talked about vasculitis, but the workup for that's normal. And usually the lumen gets narrowed. We talked about IgG4 disease. That workup was negative. Kawasaki's in an older 60-year-old would be really unusual. And they usually have elevated, inflammatory markers. Lymphoma would be a possibility, although why would it only involve coronary arteries and they're not even in continuity? So I don't know. I mean, Travis, you do cardiac. Have you ever seen anything like this?
I'm thinking, I had a friend show me a case, not this severe, that they never knew what it was, but I always thought it was vasculitis, but I don't know. It almost other things you can think about, like, I don't know if you could get segmental arterial mediolysis, like you get in other medium vessels like the SMA. It almost looks like that.
Mm-hmm.
Or, I don't know. I've never seen this before, personally.
Yeah.
I've never seen it either. It's very dramatic in the tissue.
Yeah.
Mural abnormality.
The circ does get a little narrowed, sort of after, not too far after its origin, but it is open. But yeah, and the myocardium itself is fine. And interesting, there's not pericardial effusion. You would figure if this was all in like a vasculitis or something. I was seeing some, it almost looks like Erdheim-Chester of the coronaries, doesn't it?
Yeah.
All right. Well, we may never know what it is. The patient never came back, but I was hoping maybe one of you'd seen something like this. But yeah, maybe it is a just a weird vasculitis. Oh. All right. This is just a nice example of one. I know we've seen one of these before. So this patient has it's an incidental finding in this particular case, but you'll see right here in the inferior aspect of the heart, you've got the right atrium, the inferior vena cava, and the left atrium are in continuity right near the coronary sinus. And so this is a nice example of and you see this little jet of contrast, a nice example of a sinus venosus type ASD, but this is the inferior variant that was just incidentally detected this was a PE study done some time ago, but there is it was confirmed on a cardiac MR, which I didn't manage to save at the time. But yeah, just a nice example of that. And this, I don't know, Travis, is this type associated with anomalous venous return? Because I didn't see it in this particular case.
No, I mean, usually that's the superior.
Right. We had one of those too. That's what made me think about it.
Yeah. Does this patient have pulmonary hypertension? I'm just curious from this shunt.
I don't believe so.
That's interesting.
Well, they might. That right ventricle is getting a little big.
Yeah, one wonders.
Big. Yeah, you'd figure they would have pulmonary hypertension given the size of the shunt, but
the pulmonary arteries are not that big.
No, they're not. They're not big at all.
That was a very good pickup to actually perceive that.
I think on a coronal, I don't get credit for it, but on the coronal you can see it better actually. There you can see that little jet of contrast right there coming across. It's sort of like almost like an overriding IVC there. Okay, I'll show one more real quickly. This is just another nice example. So this is a 78-year-old male with a history of IPF, and you can see the peripheral basal fibrosis. Now this is several years back. He presents acutely worse, and now we've got sort of this diffuse lung disease. His fibrosis has progressed. He's lost some volume, but it's just one of the better examples I've seen of this. And I'll put the two CTs up side by side. All right, so this is the old CT, and you can see the nice example of UIP. It's subpleural, it's basal predominant. Really nice example. But when someone comes in acutely ill, one of the things you have to think about is an acute flare, and you can see there's all this new ground glass opacity on a background of his fibrosis. And these can be hard to interpret if you're not aware of the diagnosis, or if they have an IPF diagnosis, or that you have old imaging, because you might think, oh, this is like a fibrotic HP. But I think the clue is, besides the extensive ground glass, is that it looks like an organizing pneumonia frequently. This may be more full-on DAD, but you get this discrete lobular ground glass opacity, and then you can read through it and sort of start picking up the reticulation. And if they have more advanced fibrosis, like with honeycombing and traction bronchiectasis, you can see that. So, it is associated with a high mortality, 30-day mortality rates about 50%. And current therapy is usually supportive plus high-dose steroids, which very little literature to support, but nothing really against it. So they try it, have to rule out heart failure and infection. But they usually present to the emergency department. So it's not uncommon to see these on a PE study, and just recognizing that the background of fibrosis plus new ground glass or consolidation could be an acute exacerbation, but it is a diagnosis of exclusion. Okay, I'll stop there for now. I may have one more for later. I'll turn this over to Howard.
All right. The presentation for this patient in terms of symptoms apparently occurred in December, when he, at his home where he lives, developed some set of symptoms. I don't know what they were, but a diagnosis of a pleural effusion was made. Apparently it was large. It recurred after removing pleural fluid. On one occasion, an unusual organism, and I don't know what it is, was apparently seen on a gram stain or something, but it was an unusual organism, and I think folks didn't know what to make of it. So with the presence of a persistent pleural effusion, and I think it accumulated quite quickly after tapping it, he was referred here, and that's just basically what he had. He had a chest tube placed, but in spite of that, there was just persistent output of pleural fluid. And then somebody smart got the history that back in July, he had a diagnosis initially in May of a renal lesion, which is that one. In July, he had an RF ablation procedure of that lesion, which apparently just went well. And then, of course, some time elapsed before his pleural effusion ostensibly appeared and became rather troublesome. So someone smart basically measured the creatinine level in his pleural fluid. It was around 50, compared to, of course, his serum was 0.8 or so. So they thought of urine, basically. And then the CT was done. So initially, when one does the CT, one can get the early phase, which would look like this. Now he does have a tube in, and there is the ablated lesion. But the important point here is to wait a while. So they scanned him quite a bit after that again, and that shows the diagnosis of a communication between his collecting system of his kidney and the pleural space that you see there. So a late complication of a nephro or collecting system to pleural space fistula. Diagnosis was made. Undoubtedly a late complication of that procedure. Rather odd, isn't it?
That's, yeah. That's impressive. So it's a urinothorax then, essentially.
Yes, exactly. Exactly. So they did a nephrostomy, and they're hoping that by diverting the urine, that this tract, this fistula, will close by itself over time. But once this was discovered and suspected, everything made sense. So rather unusual. I've not seen that before myself, but of course that someone suspected based on that history ultimately. And then once they got the creatinine level around 50, they went right for the CT.
Wow. Yeah, I mean, yeah, it's not uncommon to see pigtail catheters that cross the pleural space into the retroperitoneum or into the kidneys, and you end up with an effusion if they're draining an abscess or something. But I've never seen a delayed urine, ureteral or renal collecting system collection like that. That's amazing.
Yeah, that's quite a thing, isn't it? All right. Two more complications of procedures are coming up now. So the first one is in the context of a big operation for management of a thoracoabdominal aneurysm. And I'll give you some surgical details in a moment. But this after the surgery for the aneurysm, in which they basically put a graft that went from the descending aorta, a multi-armed graft, thoracoabdominal, with many connections from the graft to all the major vessels in the abdominal aorta and beyond. This is his post-operative radiography with the expected things after the big operation that involved at least the chest. So that's on the 20th. And let's go to the 26th, in which there is a small abnormality. But when we get to the 30th, the small abnormality here is now a large abnormality. And we see that we have a large air-containing structure in the basal left hemithorax. When we go to the CT, I'll just go back, say, from posterior to anterior. Here is the graft with many arms that go to the visceral vessels, and that looks intact. But then we come anterior, and now things get really complicated because it's hard to see what's where. But certainly there are things in the chest that shouldn't be in the lower chest. So here we have the stomach. Here you can see a knuckle of transverse colon going up there. You can see the spleen is also going up there. And when we get rather quite anterior, it's even more confusing perhaps, other than knowing that mesenteric fat and the spleen are all in the chest, which they shouldn't be. It's actually hard to see where the diaphragm actually is and where undoubtedly the hole starts and where the hole stops. But clearly there's a large diaphragmatic defect with herniation of abdominal contents up there. Here I'll show you a description of what they found at surgery, what they had to do. So this is the first procedure, and I don't quite know exactly what you have to do when you do these big operations, but they described at the time of the first operation taking down the diaphragm in a circumferential fashion, leaving a rim to reconstruct. But that was the first operation. When you look at the second operation and what they found, and you can see what has herniated up there, you can see that there was a lot of abnormality, particularly involving the anterior diaphragm, and it was such a large defect that they couldn't really get the diaphragm back to the chest wall, and they had to use a patch repair to actually try to fix a very large defect, which is anterior in location. So that certainly goes along with what's described here, where I guess the diaphragm is away from the chest wall up here. And this is just a big defect there. It's hard for me to make out exactly what's going on. But pretty obvious findings of a diaphragm injury, which turned out to be pretty substantive, as you can see there. The second operation I'm going to show you is in the context of esophageal cancer with a transhiatal esophagectomy and a gastroesophageal anastomosis in the upper chest with creation of a tubularized gastric conduit. And we see the gastric tube coming down the esophagus, down the tubularized gastric conduit to the abdomen. None of us will be surprised that there's opacity in the basal left hemithorax after a big operation, pleural fluid, atelectatic lung. So far, so good on the fourth. Now let's go forward to the sixth, and you see a change. Now we see an air-containing viscus in that location. And if we go to the seventh now, a couple days later, sorry about that, very clearly there is bowel in the lower chest, and it sure looks like colon up there. And indeed, that is the case. Here, the defect is not so big. Make that go away. That it's a bit easier to actually see it. So there is this gastric conduit here, which goes into the lower chest, but away from the diaphragmatic hiatus, one can actually pick out the defect, which is down here, through which there's mesenteric fat and the portion of colon. So here is the defect, which is lateral and a bit anterior to the esophageal hiatus of diaphragm. But again, I think if we scroll around, you can see the defect between about there and about there in the diaphragm. So sure enough, they had to take that patient back to surgery as well. Here is the description of the fix. They found that they were easily able to reduce the colon back into the abdomen, identify the hernia, which they described as kind of anterior and to the left of the hiatus, and fix it. So two cases of diaphragm injury in the context of surgery, very close to the diaphragm, of course, in these instances.
Okay.
Very good. Those are my cases for this week.
All right. Travis, do you have a few more?
Sure. This one turns out to be a nice companion for the foregut duplication cyst that I showed a few minutes ago. I forgot I had this one in the queue, or I would have showed it in succession. And here you can see that the major abnormality is left, or is right of midline here in the right, right mediastinal area. And you think this could be a right aortic arch. And of course, whenever you see this, you think, is it right or is it duplicated aortic arch? Here we see that there still looks like there's a normal left-sided aortic arch. And it's got a little bit of a more oblong configuration to it. And then I think on the lateral, it removes any doubt that it's probably not associated with the aorta, because it's much more well circumscribed, kind of heading back into the retrotracheal clear space here. This is the CT. And you can see in this case, there's a lot of streak. This is an older study, and also it's on lung window. It's a lung kernel, so it's a little noisier. But this was higher in attenuation, kind of intermediate attenuation. I think they actually did an MRI at the point at the time of this exam as well. This is I know I've shown at least one or two cases. David's shown some as well that are much larger than this. But we think about foregut duplication cysts in this area. But the other thing to think about, especially if it is heterogeneous at all, is a nerve sheath tumor or a smooth muscle tumor, certainly coming from the esophagus. This was separate from the esophagus. So as opposed to a foregut duplication cyst, this did turn out to be a schwannoma in the right paratracheal space. And this was, when they went to surgery, arising from the vagus nerve on the right side. So another just nice radiograph finding that could be easy to overlook if you're not familiar with your normal contours, but I'll take on the lateral view, it, obviously should jump out at anyone there.
Very nice.
And this is one that I saw, and sometimes you don't know what to do with these. This was just a preoperative radiograph that I saw last month. And again, focusing on the lateral, the PA view looks good, but I noticed that the trachea is a little deviated there, and there were actually, for whatever reason, they conveniently did two laterals because they thought the positioning on the first one wasn't as good as on this one. And you can see there's a little bit of buckling of the posterior wall of the trachea here, and you certainly have something that's occupying the retrotracheal space or Rader's triangle here. And no correlate on the PA view that I could see. This is mostly sternum right here, but I was thinking that this was probably going to be an aberrant vessel, an aberrant subclavian artery. And I talked to the clinician. They were going to talk to the patient. It turns out the patient did have some reported history of dysphagia. They're almost 70 years old, so I wasn't excited about them doing a CT, but I said if they wanted to, they could, and they did. And here you can see, sure enough, that there is an aberrant right subclavian artery. I doubt this is causing any symptoms, but that's what the correlate is for that radiographic finding. So somewhere that I look, and we occasionally see these, but I don't know if I really contributed anything beneficial to her care by seeing this, because I don't think this is causing symptoms, but it's a nice radiographic finding there.
Yeah, it's subtle, good pickup. It's not very large at all, of course.
No, and in my lateral radiograph talk, I have a big esophageal cancer sitting right here that's doing a similar thing to the trachea. But I guess there's always the possibility it could be an esophageal tumor. So but it sounded like she was minimally symptomatic and had been long-standing, so it was probably not going to be anything of consequence. And this is kind of interesting that this diagnosis. This is a patient with long-standing heart failure at an outside hospital, and they came to us for heart transplant. You can see fairly large heart. They have an AICD in place at this time, and that was in the summer. Then they're listed for heart transplant. They come in with all the signs that Howard in particular loves to talk about in the setting of heart failure and pulmonary edema, with effusions, visual thickening, a lot of curly lines, a lot of peribronchial cuffing, just kind of a generalized haze in both lungs. And you'll see that on her CT, that I want to focus on her heart, she has a dilated left ventricle. And dilated cardiomyopathy is certainly common. And when you see a dilated cardiomyopathy, usually it's ischemic, or there's a whole host of non-ischemic causes. But even just the fact that it dilates, you can end up with increased trabeculation. But the one clue in this case is the fact that while there's increased trabeculation, it's the compacted myocardium that's really very thin here. So it's about 2 or 3 millimeters, as opposed to all of this compacted myocardium, which is going to be at least 1 centimeter. And so this, because I think a lot of times people like to try and diagnose non-compaction cardiomyopathy, but it's often just increased trabeculation in patients with hypertrophy and dilated cardiomyopathy of other causes. But this is actually now a path-proven case when she went to explant and heart transplant of a non-compaction cardiomyopathy. The one issue with these patients too is because you have all these crypts and these areas of dilation, and you have just hypokinesis, that these can be prothrombogenic and can cause strokes. And she's actually had TIAs in the past. It was just surprising that they did not make this diagnosis until the heart transplant was done here, because all of the rest of this was done elsewhere. So, path-proven case of non-compaction cardiomyopathy.
Very nice.
Yeah, and I've got 2 more. I'm going to show these now. Jeff, I think, did you show a case of Mounier-Kuhn last week?
I
when
did.
I was gone. I saw it in your list. Yeah. Actually, I'll start with that one then, and I'm going to contrast it with another case, because I was actually found another case I want to show that was called tracheomegaly that I'll discuss. But this is a patient from a few years ago that I found, and I mean the trachea is, not only is it enlarged, and you can use the cutoff values of whatever, 28, 29 millimeters, but it's not just that, because you often, it's typical to see this kind of lemon shape of the trachea. And I thought this was a really interesting one, because there is bronchiectasis, but I'm curious what you guys think about some of these air spaces surrounding the bronchi, because it's certainly bronchiectasis with the large trachea, and this morphology is compatible with tracheobronchomegaly. And she was, underwent genetic testing and whatnot, and was, found to have that at an outside hospital. But this is kind of a weird look to it. I'm curious what you guys think about it. Or have you seen cases that look similar to this, with kind of these loosened areas surrounding the dilated bronchi?
Do you think it's just like damaged lung from infection?
Yeah, I don't know. Maybe. I mean, almost want to say some of it looks like emphysema in places, but it's just the distribution is odd.
If you go to the lower lung zones, aren't they?
Yeah. There's a lot of there's a lot of overinflation here, and it almost looks like there's panlobular emphysema in the lower lobes. That's the other question too, is I don't know what that is, but yeah, it's a weird case, because I was wondering if it could have been all alpha-1. Her alpha-1 was negative. So she does not have alpha-1 antitrypsin deficiency, and the trachea is so characteristic of tracheobronchomegaly. I don't know.
I wonder if she's got a disorder that no one has diagnosed, but the common theme being something that really messes up your extracellular supportive matrix in the lungs and the airways, because it's so flagrantly abnormal, not just the airways, but also the lung.
Yeah. Well, I think she went elsewhere, and it may have been to Stanford, where they did analysis and diagnosed her with tracheobronchomegaly. But yeah, I don't know. I mean, I think it just goes to show these are more heterogeneous than we think in general. But I showed that just, because it's kind of a curiosity case, but the morphology of the trachea certainly fits with that. And then I'll contrast it with this. This is not a diagnostic dilemma in the lungs, and Jeff's already shown a case of this, but this would be considered a definite UIP pattern. We have a peripheral subpleural reticular abnormality, a lot of traction, and then you have clear honeycombing with stacked subpleural cysts in multiple lobes. But the reason I show this is just because this patient was also commented to have tracheobronchomegaly, and I think somebody put a caliper on this and found that it was, over 3 centimeters, and so the question of some sort of tracheal abnormality was raised elsewhere. But this is not an uncommon finding to see in patients with fibrotic lung disease, and I think it's just, whether it's I don't know, Jeff, your knowledge of the mechanism of this developing, whether it's just from the abnormal flow from these patients, the abnormal pressures in the airways, or whether it's actual just like stretching of the trachea from concomitant fibrosis. I know I've seen it more commonly with sarcoid, especially when you have upper lobe fibrosis, but
Yeah,
this is certainly not one where we would be worried about tracheobronchomegaly.
The morphology is important, I think, more than the diameter. Like in the case you just showed, where you have that very abnormal looking trachea.
Right. This is why I'm not a big fan of the using numbers to measure. It's more the morphology. When it's spherical like this and just uniformly dilated, it's usually secondary to whatever is going on in their lungs.
Yeah.
So, but
even the previous patient, Travis, she shouldn't be labeled as Meunier-Kuhn. There's too many features about it that are so atypical.
Yeah.
That she shouldn't have it. It's just not typical of that at all.
But it is, I mean, it's tracheobronchomegaly, right? I guess
so much attached to the other findings. You may not be able to give it a name, but there's something very wrong with the lung parenchyma as well.
Yeah, that's true. I mean, I don't know. I mean, they've given her clinically a diagnosis of that, working her up for other things, but it is an odd look. So I just didn't know if anyone else had seen cases that look like this, given a diagnosis of Meunier-Kuhn, or if it's something else. But yeah, you're probably right that it's, I mean, clearly the trachea is abnormal and the airways are abnormal, but there is more to it than that. So
that's crazy. Okay. All right. Well, why don't we stop here?
That's it for me.
Okay. Well, thank you.
So we may skip next week, Jeff, do you think?
I'll be back.
I'm around.
Late Wednesday night.
Okay, that's fine.
Yeah. We'll plan on it and see how it goes.
Sure.
All right, guys.
All right. Take care and have a good time at STR.
All righty. Thanks, everyone.